Give everybody a couple of minutes to pop in from the waiting room. That was at the top of the slide deck. .501, so we'll just give everybody one more minute to log in. Welcome to the ATS COVID Critical Care Training Forum. All right. Well, happy Tuesday evening, everybody. We're running our usual weekly session on ATS COVID-19 critical care. Today, we're going to talk about resuscitation in COVID-19. So I'm excited to introduce Rebecca Sell, who is a professor of medicine here at UCSD. She is a guru on all things resuscitation oriented, but she's also a master clinician and clinician educator. She's gotten so many teaching awards that she's stopped allowing them to be given to her. So I look forward to her teaching us today. And then Dr. Katherine Berg, we're very lucky to have from Beth Israel Deaconess, who is one of the directors of their Center for Resuscitation Science. And then we have our lovely fellows, Cameron McGuire and Dr. Brinda Desai, who will be presenting as well. I have no relevant financial relationships. Dr. Nirav Shah has a Boehringer Ingelheim relationship, but it should not apply today. For CME credit, we invite you to fill out our evaluation and get CME credit. So this is the link to the evaluation, which will tie it to the CME, and we'll be posting this in the chat box intermittently. But this is the QR code if you want to grab it. We can put it up at the end of the session as well. We have done many sessions on this weekly COVID critical care training forum. So if you're interested in a certain topic, it might already have been done and posted. All of them are freely accessible on the ATS website, so please take advantage of them. You can actually just Google ATS COVID forum and that will take you right to our webpage. We have some great topics coming up after this week, outcomes and challenges for patients with pre-existing lung disease in COVID, COVID-19 in patients with HIV, COVID-19 and lung transplantation, vaccine development and immune responses, and ECMO and COVID-19. So an exciting few weeks coming up. I'm one of the chairs along with my colleagues, Dr. Nirav Shah, Dr. Shushma Cribbs, and Dr. Viren Kaul. We have a team of trainees that helps us out and they're amazing. But it's really the ATS staff, Lauren Lynch, Liz Guzman, Eileen Larson, and Rebecca Fish who do the heavy lifting to put this forum on every week and get you guys CME credit. So thank you much. And with that, I will stop with all the intro mumbo jumbo and hand it off to our very own Dr. Rebecca Sell.
Thank you, Dr. Crotty.
Feel free to place questions in the chat box and we'll be moderating and typing responses throughout.
Perfect. Thank you for that introduction, Dr. Crotty. And I wanted to introduce the people that are joining me today. I'm really lucky to have a couple of other really wonderful physicians to help us talk about inpatient cardiac arrest in patients with COVID. Specifically, I want to highlight that this is for patients who are in the hospital, admitted with a diagnosis of COVID, whether that's the primary diagnosis or an additional diagnosis. In addition, this is not focused on resource limitation or triaging. This is in a setting where we have adequate PPE, beds, physician, staff, and nursing. So the first person I'd like to introduce is Dr. Kate Berg. She is an assistant professor from Beth Israel Deaconess in the Division of Pulmonary and Critical Care Medicine. She's also the director or the vice chair of the AHA Cardiac Arrest Guidelines Writing Group. And we're going to be referencing some of her work related to that and her work with the task force at ILCOR. In addition, we have Dr. Cameron McGuire. He's one of our second-year fellows, interested in clinical education, med ed. And then we have Dr. Brinda Desai, one of our amazing first-year fellows who jumped in right away and got to work with me. So she's learned a ton. Or maybe she already knew a ton and I've learned a bunch from her. Okay, so we're gonna start, if I can share my slides, hopefully. Okay, they came up, that's a good start. All right, per usual, we're gonna start with a case presentation. We'll move on into a little bit of background in hospital cardiac arrest in general, and then with regard specifically to COVID-19. We're going to delve into the guideline recommended modifications to ACLS protocol, including a focus on PPE, airway, mechanical or automated CPR devices, goals of care, and prone positioning. And then we'll touch on the Beth Israel Deaconess and the UC San Diego experience in the sort of the general approach as well as outcomes to cardiac arrest in the inpatient setting when patients with COVID. So with that, I'm going to move on to Dr. Desai with a case.
Great. Hi, everyone. This is a case that was here at our ICU, at the Jacobs ICU. So near the beginning of the pandemic, a 61-year-old gentleman presented with a week of fevers, cough, shortness of breath, and a positive COVID-19 test. He rapidly required increasing amounts of oxygen, as you can see on his vitals graph there, and was intubated. He was managed with standard lung protective strategies in higher PEEP, sedation, paralytics, and prone positioning with improved oxygenation. And then on the night of hospital day 2, the patient was switched to a transporter vent to be moved. And outside the room, he unfortunately acutely desaturated with sustained hypoxia. He became bradycardic and lost his pulse. Code blue was called. He was pushed back into his original room. CPR was initiated and he received 1 milligram of epinephrine. And after 3 minutes of CPR, ROSC was obtained. The patient spent about 31 days in the hospital, and then he was discharged to a long-term acute care facility after receiving a tracheostomy. He's now home, breathing on his own and improving. So just a little bit of background on in-hospital cardiac arrests. Causes of cardiac arrest in the hospital are divided into 2 big categories, accounting for cardiac, about 50 to 60%, and respiratory etiologies, about 15 to 40%. The incidence of in-hospital cardiac arrest is about 290,000 adults a year, with the mean age of being 66 years old. Men accounted for about 58% of this. And the most often presenting rhythm was non-shockable, about 80% of the time. And then the survival to hospital discharge has been increasing over the last 2 decades, about now 20 to 25%. Next slide. And this is just important to note, if you compare the in-hospital cardiac arrest with out-of-hospital cardiac arrest, there are some key elements that we want to point out the differences. One specifically in prevention of cardiac arrest in the hospital is often possible with recognition of deterioration and early intervention, whereas in the out of the hospital cardiac arrest side, that's not as possible. And then timing of advanced life support drugs is within 5 to 10 minutes in the hospital versus much longer on the outside of the hospital cardiac arrest. And then survival to discharge, if you notice, it's approximately 25% if in the hospital and 10 to 12% out of the hospital cardiac arrest. And then the key elements, I think, to kind of review for everyone, I'm sure all of you know, for successful resuscitation protocols: chest compressions, ventilation, early defibrillation if it's applicable to the case, and then immediate attention to potentially reversible causes. And this will come up again when we talk a little bit more about our in-house cardiac arrests. Number one thing in terms of goals, identify the cause of in-house cardiac arrest, and that goes back to your H's and T's, specifically because it's shown that this could potentially improve outcomes, and then this does have post-cardiac arrest implications if ROSC is achieved. The first link Prevention is kind of the first link in the chain of survival for in-hospital cardiac arrests. And this really means identifying at-risk patients. So patients with vital signs that are deteriorating or clinical picture that kind of shows that the patient is not heading towards maybe the goals that you want, and there is risk for cardiac arrest happening. And then creating appropriate interventional responses. So I think many hospitals nowadays have rapid response teams, teams that respond to essentially deteriorating patients and cases. So I think that's important to kind of have that as part of your system. And then next slide. And then management, like we said, chest compressions, ventilation, and early defibrillation when applicable are the cornerstones of cardiac arrest treatment. The quality of chest compressions and of CPR in general is associated with better outcomes. And then there's data supporting the efficacy of medications during in-hospital cardiac arrest, but they're quite sparse. For in-hospital events, early administration of epinephrine in patients with a non-shockable rhythm is associated with better outcomes. However, early epinephrine for patients with shockable rhythms is associated with worse outcomes. And again, these are very limited data that this is coming from. And then airway management is key, but I think some of the things we're learning now is that, you know, whether it's the traditional endotracheal intubation, whether that may be helpful or not, is up for debate now, especially with emergent evidence in both out-of-hospital and in-hospital cardiac arrest that suggests alternative approaches may be equally or even more effective. And then if we go on to the next one, you know, we talk about characteristics related to outcomes. So two of the factors most strongly associated with outcomes are the presenting symptoms and the duration of the cardiac arrest. Increased age is associated with decreased survival following cardiac arrest, and especially post 65 years of age. And then the presence of pre-existing medical and surgical conditions are associated with worse outcomes following in-hospital cardiac arrest. And then to kind of talk a little bit about the relationship between race and outcomes, Black and Hispanic patients have a lower rate of neurological recovery and survival following in-hospital cardiac arrest compared with white patients. However, recent data in 2000 showed that the differences between the two have been narrowing compared to 2000 to 2014 from 4.5 to 1.8%. And then, as many of us probably know, that there is little evidence for any one tool for prognostication after in-hospital cardiac arrest.
Kate, did you want to add something to these guidelines or a review?
No, I think it's a great summary, and thanks for focusing on our little review paper. I guess a couple of them. One thing I would say about epinephrine is that what was looked at which were studies from with the guidelines database that the AHA has, so it's a national in-hospital cardiac arrest registry, and really showed for non-shockable rhythms that basically the earlier you got epinephrine, the better your survival was, and also neurologic outcome. And then for the shockable ones, looked specifically at whether giving epinephrine earlier than the guidelines say you should give it, so the guidelines say after the second shock. And if people got epinephrine before that, so after the first shock, they seem to have worse outcomes than people who were sort of matched by time and did not get epinephrine early. So just to clarify that one point. And then I think the airway stuff, and I know we'll talk about this later in changes in COVID, I think that the evidence suggests that the best approach also kind of depends on your environment. So if you're somewhere with a really high first intubation success rate, then it's really equivalent, whereas a low success rate environment that might be, out of hospital with providers that don't do intubations as often, might be better, like you said, Dr. Desai, to use, bag mask or other airways beyond less invasive than endotracheal tubes.
Great, thank you. I think one of the interesting things to think about is what caused the arrest in general.
Mm-hmm. Yeah, I think I recently was working on a paper about cardiac arrest research, and I think especially with in-hospital cardiac arrest, it's hard to do studies on it because really, in my opinion, you're sort of studying a final common outcome of many diseases rather than one single disease process. So, like you said in your presentation, I think that the reason the patient arrested is probably the most important thing to figure out aside from doing the basic resuscitation.
Go ahead, Brinda.
Thank you for that. And I think, the big thing that we're going to talk about, and Dr. Sell is going to advance to the next slide and kind of present. So it looks overwhelming, but it's not. And I think this kind of hones into the prevention and kind of identifying risk factors for your patients that put them at risk for cardiac arrest. So really identifying the etiologies of the cardiac arrest, which we have a better chance of doing in the in-hospital setting than we do on the out-of-hospital cardiac arrest. And so if you look at this matrix, this is the ART matrix of arrest that kind of breaks it down into why is the cardiac arrest happening. And so circulation, respiratory, dysrhythmia versus neurological and unknown, and then kind of even breaking that down further into what is the specific etiologies leading up to that event. And I'll pass it over to Dr. Sell to kind of talk a little bit more about the details of this specific matrix here.
Thank you, Brinda. I think this is one of the really cool things about inpatient cardiac arrest is that you can really get a sense of why your patient died most of the time by reviewing the chart, looking at imaging, autopsy, if that's unfortunately the result. But a person who dies from a PE may have a very different likelihood of successful ROS than somebody who dies from, an intubation that goes poorly, or, a hemorrhage or a brain injury. And that can certainly inform the type of resuscitation you might want to do if you're going to look at more personalized medicine. Despite that, the recommendations still are that the best evidence is quality CPR, early defibrillation, and probably early medications-ish. So the question is this still true with COVID? Has COVID-19 changed the way we should do CPR? So the caveat to this is there's very limited published data on this, but this article came out in Resuscitation in April 2020, and it was a review of all in-hospital cardiac arrests in Wuhan, China, in patients with COVID-19. And of 761 admissions, they reviewed 136 patients who were resuscitated. Unfortunately, only 13% achieved ROSC, and only about 3% were still alive at day 30, which is quite poor. When you look at the data a little bit more closely, you can see that the original initial rhythm is mostly asystole, and additionally, it's mostly on the general wards. This suggests that potentially in the midst of a massive pandemic that was slightly overwhelming, patients may not have been caught quite as quickly as one would hope. I might ask Dr. Berg to comment on this article as well if she wants.
Sure. I think, I remember looking at that paper, and I think even in addition to most of the patients being on wards, a lot of them were in like improvised wards, so sort of temporary hospital wards that they built because they were so overwhelmed, which I think, to your point, a lot of them were arresting in a relatively unmonitored setting. And even in non-COVID times, if you arrest on an unmonitored, non-telemetry ward, your outcome is much worse than if you arrest in an ICU, where the response time's a lot faster.
I just learned that the screen maybe isn't showing quite well. Do you want me to not screen share? And Kate, do you want to take it, or do you want to?
Sure, I can.
Okay. Thank you.
Okay. Should I go ahead, Rebecca? Are you?
Yeah, go ahead. I think that's good for that.
All right. Okay, so I just wanted to spend a few minutes talking about, what I think a lot of people are interested in, and I know our department, our hospital had a lot of questions about when this all started, which is, are there ways that we should modify resuscitation of in-hospital cardiac arrest for COVID-19? And the American Heart Association, as well as ILCOR, which for people who don't know is an international group that AHA is part of that works on international treatment recommendations for cardiac arrest, both have put out some interim guidance on this. So this image is just the ACLS algorithm that the group, and I did not work on this specific document, but the writing group for the COVID interim guidance put together. And they basically just inserted some modifications for the COVID-19 pandemic into the algorithm, and I'll kind of focus in on each one of these points. So the first was PPE, so this is really about minimizing risk to personnel, so limiting people in the room donning PPE, and they also have this consider resuscitation appropriateness. And the, my own opinion is that at the start of a code is probably not the time to be having the goals of care conversation, that, we need to be thinking about that well in advance, but they did put that here in the algorithm. And then starting CPR, they mentioned specifically trying to limit aerosolization and prepare to intubate. So, as Dr. Desai mentioned earlier, in non-COVID times, whether you intubate somebody or just manage their airway non-invasively is probably equivalent, but in this, I think people have moved towards earlier intubation to minimize aerosolization. And then the next arrow here is, again, prioritizing intubation. So this is, again, about really focusing on getting a closed circuit airway quickly. And also talk about, considering not bagging a patient, trying to avoid anything that can cause additional aerosolization. And then further down on the algorithm here with ongoing CPR to consider a mechanical compression device. So I'm going to go through a few of those things. So this is just a picture that Dr. Sell actually sent me of a typical in-hospital code. This looks like probably a floor room, not an ICU room, but lots and lots of people wearing some masks, but I don't actually see that they're wearing N95s. So just to kind of zero in on the different modifications in the algorithm. So the first one is that provider protection, and then I think in thinking about appropriateness of resuscitation is both about whether you think their outcome is guaranteed to be poor, in which case CPR is futile, and also resource allocation, which I know Dr. Sell said we're not going to focus on. But and the first and most important thing is just don't go in the room without aerosol appropriate PPE. And both ILCOR and AHA have specified that it should be aerosol appropriate. So it's based on very limited evidence. There was a systematic review done this year looking at infection transmission with CPR and defibrillation, and they really didn't find a lot of data. There's a couple observational studies from the SARS epidemic, and some of them showed increased infection transmission in healthcare workers who had done CPR or participated in resuscitation in a SARS patient compared to, somebody else who took care of a SARS patient. But other studies really didn't find any difference. And of course, in resuscitation, there are a million interventions happening. So trying to pinpoint whether it's the CPR or the defibrillation or what's causing the aerosolization is really hard. Everyone agrees you should just limit who's in the room as much as you can. And hospital codes tend to be overcrowded, but it's more incentive to change that. And then they do talk about the appropriateness of CPR, but again, I'll come back to that one. And then for the aerosolization risk, someone did recently do a mannequin and cadaver study where they basically aerosolized like a UV detergent into cadaver and mannequin lungs, and then had volunteers do CPR on them, and then used a UV camera to try and pick up the aerosolization. And they basically found that really an advanced airway with a filter in place was what stopped the aerosolization, and a mask over the patient's mouth didn't do anything, and endotracheal tube, as you can see in this upper right picture, still aerosolizing.
I think one of the concerns about the exposure risk during CPR is it's hard to separate out the actual intubation from the chest compression and all the rest. So it can be pretty hard to figure out.
And I know some centers have moved to using these sort of plexiglass boxes over the patient's head during intubation. We have not done that, but but clearly it's, I think getting the airway in and the filter on there seems to be the most efficient. So the second and third modifications are really all focusing on establishing a closed circuit airway quickly. So in 2019, the AHA came out with the guidelines saying that either bag mask ventilation or advanced airway is okay, and that which you use kind of depends on provider expertise and intubation success rates, et cetera. But for COVID-19, they really have recommended early intubation. And then the kind of practice of using the most experienced intubator. So this might not be the best one for your July anesthesia resident to do. Pausing compressions during airway insertion, which in general has not been recommended. So, and this is just to minimize the risk of aerosolization while the anesthesiologist or the intubator is, over the patient's head. And then consider not doing bag mask ventilation prior to intubation, or if you do it, to especially focus on a tight seal and using a HEPA filter, and also to consider video laryngoscopy, because just the position of intubating with the video laryngoscope, you can be, upright and further away from the patient's mouth than you are if you're using traditional methods. And then finally, they recommend considering leaving intubated patients on the ventilator. I think logistically this can be challenging with, vent alarms adding to the chaos of the code and other, definitely my preference is usually to just bag a patient. So, and I think you can do that safely with a filter and an intubated patient.
Agreed. You would have to switch to a pressure control mode and override alarms quite a bit.
Yeah.
It can be quite hard.
It seems like something you don't really want to have to think about during a code, but so, and then the fourth modification was to consider a mechanical CPR device. So these, have been looked at in several studies. So this is the one our hospital has, is the Lucas device. There are others. In general, their AHA does not recommend them for routine use for CPR. They recommend manual CPR as first, so the sort of gold standard, and that's because there have been some randomized trials done when the outcomes were definitely not better with the mechanical devices, and there actually was a trend towards worse neurologic outcome when they were used. So the previous guideline, again, pre-COVID, was that if there's a situation where CPR is difficult to continue to do, like if you're in an ambulance and you don't have enough people to provide the CPR in the ambulance, or if you're in a place where it poses risk to providers, then you could consider using a manual CPR device. And so I think in light of COVID-19 being a setting where there could be risk to providers, they have suggested that if you're a hospital that knows how to use them, you should consider making the use of them more routine for COVID-19.
Great.
And then finally, goals of care. So I think this is, to me, it seems a little odd to see it at the beginning of the algorithm, because I think really, and what we've really focused on at my hospital is trying to, and we always focus on this, but especially now, just trying to have goals of care conversations ahead of time and try to really, if someone really seems to have a poor trajectory, otherwise lots of comorbidities, poor chance of good recovery, just making them DNR early. And, the AHA did put out, part of this document was talking about considering the appropriateness of CPR. And I think it's not clear to me that should be emphasized more for COVID-19 than for other illnesses. Initially, certainly there were concerns for a need for resource allocation, but that, in most parts of this country, at least, has not really come to fruition and not been a major issue. And there really are, it's already has been highlighted, very limited data on COVID-19 cardiac arrest outcomes. So I think most of those bad outcomes are probably from overwhelmed centers. So to me, goals of care shouldn't necessarily be different in this population than in any critically ill population.
Definitely agree. And I think with COVID-19, if it's a progressive COVID-19 illness, either profound hypoxia or myocarditis or something like that, you have time to have those conversations to some degree.
Yeah. No, and I think, the moment of a code, both for the family and for the providers, is really not the best time to be making those decisions.
Yeah. Okay, I think we're going to, Kate, do you mind letting Cameron share his slides for this part? Thanks.
Great. Thank you, Dr. Berg. I'm going to share my PowerPoint here. Same PowerPoint. All right, great. So I'm going to focus on the prone patient. So in this time and age of COVID, ARDS, with a lot of patients getting evidence-based ARDS management, obviously we have many patients who are prone, and I think a major fear of many providers is that a patient will suffer an in-hospital cardiac arrest while in the prone position. So I wanted to delve a little bit into the guidelines around this and some of the evidence that underlies it, and then I think the remainder of the discussion will be sort of perhaps Dr. Sell and Dr. Berg talking about somewhat different philosophies perhaps at each institution. So prone CPR, there are some recommendations from the AHA. They are included in this consensus report that was released sort of partway through this COVID pandemic, I believe in April, with some updates from the most recent AHA guidelines, of which Dr. Berg is one of the contributing authors. This is the entire text of that recommendation regarding cardiac arrest in prone patients. I'm underlined sort of the important part at the bottom, but let me summarize the remainder that's not underlined. They basically say to attempt to place the patient in the supine position prior to attempting resuscitation, given that the effectiveness is relatively unknown. However, they do say that you can indeed do this in patients who are still in the prone position, and if so, you should be compressing over the posterior spine between vertebra T7 and T10. This is a reference that I looked up because I was a little interested in the data that underlies these recommendations, and it's from a paper in 2003. So it turns out that this is actually probably fairly relevant. This is in the short interim between when these guidelines were released in April and last month, showing just 4 different headlines from various journals where people wrote letters to the editor asking for more guidance in this. So I wanted to delve into the evidence behind that single recommendation that the AHA references. So prone CPR was actually first proposed in 1989 in Resuscitation. We'll see multiple references to that journal here. It's actually a modification of something that came about in the early 1900s, which was a modification of an apneic ventilation protocol used by a Danish physician in 1932 for patients who had either drowned or been caught in avalanches. Here's a modification of his modification that was published in a British guidelines on ACLS in 1951. Since that initial reference in 1989 by E.L. McNeil, there were a couple of case reports and 1 review article in the literature until 2003, when Mazur et al. Published their study, which is the one referenced by the AHA. And this is that title of their study. So let's look at the Mazur article really quickly. It was done at Columbia in New York City. They took 6 patients who had died either in the cardiac intensive or medical intensive care units from a cardiac arrest, 4 from PEA and 2 from VF or VT. Those patients then had 30 minutes of standard CPR without return of spontaneous circulation. At that point, they were enrolled in the study. That meant making sure that they already had an arterial line in place and that the arterial line was zeroed to gravity. They then received an additional 15 minutes of standard CPR. At this point, an attending physician who was a member of the study declared that it was futile, that they would probably not get the patient back and they could be enrolled in the study. They had an additional 15 minutes of standard CPR given. ACLS guidelines at the time in 2003 were slightly different than they are now. I won't go into those details. They then were quickly flipped into the prone position, which took about slightly under a minute. The A-line was re-zeroed and they had an additional 15 minutes of CPR given in this reverse CPR. The way this was done was while they were flipped into the prone position, a backboard, which had been modified to have a 10-pound or 4.5 kilogram weight, was placed under their sternum to offload their sternum and also allow their abdomen to be on the firm surface as well. And then compressions were initiated over the posterior spine around T7 to T10. The control was a self-control because this was a crossover trial. There were, again, 6 patients who received both the control and the intervention. And the outcome was increases in hemodynamics, specifically systolic blood pressure and mean arterial pressure. So what they showed was a statistically significant improvement in both the systolic blood pressure and the mean arterial pressure in reverse CPR or posterior or prone CPR as compared to standard. And these are the individual patient data for systolic blood pressures here and mean arterial pressures here. You'll notice there was a trend towards benefit in the diastolic blood pressure, but it didn't reach statistical significance with a p-value less than 0.05. And that was essentially the literature. That is the literature that was referenced by the AHA. So it turns out since 2003, this has actually been looked at further. This is the most recent literature. It will be coming out in hard copy in Resuscitation on October 1st, but it was already e-published on July 21st. And this is essentially a large systematic review of all of the various studies and case series that have been published up to July 21st, 2020 about prone CPR. And it actually is quite interesting. So I'm leaving this reference up here for quite a while in case anyone wants to quickly Google it. But I will summarize the high points from this study. So quickly, they looked at 24 papers. They looked at a total of 453, but only 24 could be included. 4 of those papers were original research studies. The Mazur study that the AHA references, a study that was published 3 years later where they basically did the same thing in cadavers in China, but they measured blood pressure while they did it. And then 2 other studies, one of which was actually a CT study looking at where the left ventricle lies when the patient is in the prone position, and I'll reference that study in the next page. What they found was the following. Of the remaining 20 papers that they looked at, it was either a single case report or a couple of case series with a total of 25 patients. So overall, we have examples from 25 patients since 2003. And here's what we know from those patients. 20 of them arrested in the OR while in the prone position because they were in the middle of a neuro or ortho case. So they had an exposed spine or an exposed brain and could not safely be flipped into the supine position to have standard CPR. 14 of those 25 patients were pediatric, under the age of 14, sorry. Most of them, however, were under the age of 10. 20 out of 25 did survive resuscitation. They don't, however, comment on the long-term outcomes, i.e. survival to hospital discharge, 30 days, full neurologic recovery, etc. Only 5 cases were respiratory arrest. The remaining 20, all of the OR cases, were neuro or ortho cases. And of the 5 respiratory arrest cases, only 1 was in an adult who was 48, who had pneumonia, ARDS from a bacterial pneumonia. The other 4 respiratory cases were kids with epiglottitis, whooping cough, things of that nature. So if you must do prone CPR, you can. The AHA says that you can. The case series seem to suggest that you can. Here is the recommendation of why the T7 to T10 location. So this CT study was done by Kwan et al. In, I think, South Korea. They basically looked at 100 CT chests, and they used 3D modeling of the CTs to look at where the largest cross-sectional area of the left ventricular, or of where the left ventricle was. And in 86% of patients, it was within 2 rib spaces of the inferior spine or inferior angula of the scapula. So for most patients, that's between T7 and T10. So if you are going to compress, you compress either on either side of the spine, or if you're a single compressor, you can compress in the standard bedside CPR, as in this figure here. So that's where the reference of the T7 to T10 comes from. And then again, it is important to have some sort of board that's modified to help hold the sternum slightly up. This serves 2 functions physiologically. One, it allows for counter pulsation or counter pressure against the resistance that's being provided by the compressor. And second, it slightly changes the location of the abdomen, which helps to not diffuse all of the pressure that you're applying with your compressions into the abdominal cavity, and allows it to stay centered over the LV mass. So that's all I have on prone CPR. The data are scant, but you can draw your own conclusions from them. I'd be happy to discuss further in the chat. I'm going to stop sharing my screen now and hand it back to Dr. Berg.
Thanks, Cameron. I think that was great. Some of the arguments for not putting somebody back in the supine position have to do with the likelihood of losing an airway or increasing spread of particles as they flip back. But in an institution that's pretty good at proning and supining, often they can do it very, very quickly with limited trouble. So at our institution, we decided to focus on safe PPE and supination rather than prone CPR. Dr. Berg, did you have any comments about that?
Yeah, just that I agree, basically. So yeah, I am part of the guidelines in general. I was not part of the COVID update. Specifically, I was for ILCOR, but not for AHA. And I think I really feel, I don't know, I was concerned that they weighted that very scant evidence, as you nicely outlined, a little too heavily. I think especially, like you said, that systematic review of case reports with one patient who is probably the kind of patient that we would be thinking about in this forum, right, with a critically ill ARDS patient. And I guess my own opinion is that any center that uses proning should have the ability to quickly and safely supinate a patient. Certainly if I was in the room by myself with a patient and they arrested in front of me while I was activating the code and waiting for enough people to come in the room to allow me to supinate a patient safely, I might start CPR. I think I would, but because there is some evidence that you can, get some perfusion pressure going that way. But I think for all the reasons that you already mentioned, Rebecca, that supinating them as quickly as you can is the way to go. And I think just also one clarification, I think on one of your early slides, Cameron, in case that didn't come through, is that the recommendation that they said with the COVID update, that they recommend supinating someone, that's in a patient without an advanced airway. So what they say is that with an advanced airway, to consider leaving the patient prone, or if you can safely turn them, then turn them. And I think that's the emphasis that I think a lot of us are a little uncomfortable with, because I think the priority should be on supinating as soon as you can.
Thanks for clarifying that, yeah.
I think also, Kate, the other concern I would have is that many of the times when people code in that position, it's because of a moved EP2 or a mucus plug or a pneumothorax or something that is a little bit easier to deal with when your patient is in the supine position. Mm-hmm.
Yeah, and I think my hospital's cardiac arrest data supports that statement.
Kate, do you mind showing your slides again?
Sure.
Thank you. I guess this is just a report out of UT Southwestern, I believe, in Texas, and they had several other ideas about what to do for COVID patients in the ICU that might arrest, and they summarize it here. A lot of it has to do with having your IV tubing go outside the room and how to handle that if you're pushing medications. They really try to limit the number of people that are in the room. Another big issue, which I think Dr. Berg will mention in her updates, is the importance of communication. So being able to communicate through a PAPR and a closed door about defibrillations and cardiac meds can be pretty tricky. And they recommend using handheld laminated cards, video conferencing, and telecommunications, which I think is quite clever. The next slide, I think, is Dr. Berg.
Hi.
Yeah.
Showing our location.
Mm-hmm.
So in Boston, East Coast of the United States. I know I've looked at the chat to see where people are from, and it's people from quite a range of places. So this is where we are. So just very briefly on the modifications that my hospital made. So we kind of added the role of safety officer to the code team. So to have somebody, this was usually a nurse, to be the safety officer to ensure that everybody going in the room had proper PPE on. I think it's a little bit tricky when, we were sort of given one N95 for 3 shifts, and, occasionally you forget to bring it with you when you run to a code. And so this is the person to make sure you don't go in and that they give you an extra if you need one. Limiting who goes in. So it had, sometimes pharmacy would be right outside the door instead of in the room. We started actually using baby monitors for communication sometimes, so that they, someone inside the room could talk to somebody outside the room, and then they could pass things in as needed. And then I think the biggest change that we made was we did not used to use the Lucas device, which is this mechanical CPR device. It's pictured here kind of off the patient. This is kind of the backpack format it comes in. It weighs 27 pounds, and our poor interns have to carry this to codes. And then this is it on a patient. So you don't necessarily have to strap the arms, but they recommend you put their arms up here. That's why the arms are up like that. And we did do, there were a lot of trainings on how to use it and, practicing with the house staff and nurses and everybody. So this has become much more standard for in-hospital cardiac arrest. I will admit that I am not still completely sold on that practice. And I think, with a lot of practice, you can get on very quickly and you can kind of do CPR even as it's being set up until really it's just ready to deploy and have that thing come down and start doing compressions. But it takes a lot of practice. And then we definitely have started intubating early and not masking patients before intubation in general. So that was another modification. And I think I'll be interested to see how things kind of evolve now that we are still seeing some COVID patients, but mostly, not nearly as much as before. Now most of our patients are COVID negative, to see kind of how many of these practices stick around and how many of them go away again. And then just a little bit of data, and I just was able to get kind of partial data from our peak surge months, which was kind of March to May of this year. So of the, I don't know how many hundreds, I know we discharged several hundred patients from the ICU, so the number we admitted to the hospital as a whole was much larger than that. We had 9 in-hospital cardiac arrest and COVID positive patients in that 3-month time frame. 5 out of 9 of them got return to spontaneous circulation, and 2 out of 9 survived both to discharge and to 30 days. So not great survival, but not terribly different from the national average for in-hospital cardiac arrest in general. And then, we don't know definite causes in all of them, but the likely causes, one with a pulmonary embolism. To Rebecca's point about endotracheal tube issues, we had 3 with dislodged tubes. I think some of these, in patients, we for some reason had several patients who had tubes, I think from being in there for a long time, and these patients often really had a lot of secretions that tubes could get dislodged or, start to curve and kind of rise up without people being aware. Aspiration events, one of which was post-extubation, another one was before intubation. Ventricular tachycardia in 1 patient, and then bradycardia and suspected mucus plug in 2. So definitely a predominance of respiratory issues.
Perfect. And now you move to the exact opposite of the country. In the Southwest, we have San Diego. Given our proximity to Mexico, it's changed our patient population a little bit compared with yours. We also serve a lot of the East County, which El Centro out to the east, as well as the Salton Sea area. Don't mind going to the next slide. Thanks. Okay, so after a couple of our physicians got back from the Society of Critical Care Medicine conference in February, where people were starting to get worried about COVID, it was brought to our attention that we needed to address this formally. So the Code Blue policy was updated with an interim policy change looking at what we should do for patients with known or suspected COVID-19. So not all patients, but only those that were being managed with airborne precautions. And so similar to Dr. Berg, we had a unit charge nurse who became responsible for the traffic in and out of the room. They were given the job of traffic cop. Not easy when lots of people want to go running in and see how things are going. Another concern was adequate supply of PPE. So near the beginning of the pandemic, you guys probably all are remembering that things were kept under lock and key. So you didn't necessarily have easy access to PPE. In this case, our unit charge nurse, who was the traffic cop, also held a supply of PPE. And in fact, in the upper right corner, you can see our PPE box that was created to go to floors where patients with COVID were, and also to go to some of our outpatient sites like radiology, just to be ready in case we needed them. We did limit the number of staff in the room at all times, or at a time. Specifically, you really think about all the people who respond to a code, there's quite a few. So we had 2 airway MDs, an RT or 2, a code nurse, a primary nurse, a code MD, a pharmacist, and a minimum of 2 people doing compression. So many of those people were moved outside or were allowed to leave as soon as possible. We did not bring in a Lucas or auto pulse, mostly because of the requirement to have to train staff who weren't comfortable with it at that point. We did implement intubation early. Our anesthesiologists are pretty amazing at getting tubes in, even with compressions going, but we, like Dr. Berg, allow for for pausing compressions during intubation. In addition, we still did bag our patients, but we use a 2-person bag valve mask system where the one person is in charge of the seal and the other is in charge of the bagging, which seemed to minimize exposure. Okay. So for us, we've had almost 500 patients admitted with COVID here. 6 have experienced an in-hospital cardiac arrest. All 6 did get ROSC, but only 1 survived to discharge, sort of similar numbers to Dr. Berg. You can see that we've had, I think what's remarkable about this is that most of these patients did not code from hypoxia due to progressive ARDS. They coded from critical illness with COVID. The one who coded on arrival from outside hospital as being transferred from the transport vent to the ventilator. Another with an LVAD and COVID who also had a VF arrest. Also had a patient with hypoxia, the one that Dr. Desai mentioned at the beginning of the talk. Had a patient with septic shock from diverticulitis and COVID, one with ECMO who coded during a vent change, and a poor lady with autoimmune encephalitis who developed complete heart block, but also was COVID positive. So I think what this is, it just sort of illustrates that COVID itself should not be a reason to limit or not offer CPR in the right clinical setting if consistent with goals of the patient and their family, provided that we have adequate resources and are not in a resource-limited setting. Okay. So I guess one slide back. I guess the key takeaway points from our excellent panel today is that first, there's minimal published data on in-hospital cardiac arrest. I look forward to seeing what comes out in the next year. As recommended by AHA, ILCOR, and us, we request that you minimize staff exposure. So utilizing a traffic cop or a safety officer is a really simple way to do that. And just an encouragement is that with adequate PPE, the risk of transmission is low, but we need to encourage and enforce the use of PPE and protect our healthcare providers. Early intubation is recommended in this setting, but not in general, and we should continue to offer CPR to those who may benefit, provided it's consistent with their goals. So with that, I just want to thank my panel, and if there are any further questions in the chat box, we can certainly answer those. And thank you for your attention. see a comment about SARS-CoV-1 and transmission, even with adequate PPE. I don't really have a profound thing to say about that, so I think it is a risk. Dr. Berg, did you have a comment?
Yeah, I think that might have been one of the studies that was included in the systematic review that they did. And someone else has done a trial looking at like the different kinds of N95. So there's one like we use usually like the round blue, I forget what they're called, the 860s or whatever, the 3M ones. And there's kinds that are folded. So I wish I knew the technical names for them, but the folded ones in this was a simulation study, but during CPR kind of maintained a better seal. I think someone else in the chat was talking about having to use the same N95 for 2 weeks. And I think, certainly they do, I think, lose some of their integrity over time, right? The fit is not as good. And so I think just, I suspect that when the transmission happens, it's from either, some contamination or mask slippage, which is, something that certainly can happen during especially a long resuscitation.
And probably more likely in the setting of the intubation with the airway controlled and a HEPA filter, it's probably a little less likely.
Yeah.
You also maybe wonder about poorly protected or unprotected eyes, right, during a code when things are aerosolized as well. I don't know in the case that Chad Brisendine's referencing if the person who contracted SARS-CoV-1 was wearing eye protection, but I know, we've seen that as an issue as well, even with people wearing masks with SARS-CoV-2.
Excellent point. Question about higher rate of infection of COVID among resuscitators. So I think out of China, there was a pretty high rate of infection among staff, but not specific to resuscitation, but just specific to taking care of these patients in general in the midst of a pandemic. I think in our own institution, we have had no cases of healthcare workers getting it from a patient. There certainly have been small outbreaks of healthcare worker to healthcare worker. Kate, did you have a comment about that?
Yeah, I think so. The studies I mentioned on SARS, it's sort of it's a mix. Some of them reported, they're all very small numbers of healthcare workers that got infected, at least in the studies that were published. But I think one or two of them showed that rates were a little bit higher in a healthcare worker who had performed CPR on a SARS patient. Some did not show that. So, limited data and conflicting. Not that helpful.
Again, limit the number of people in the room. Wear adequate PPE, maybe a hopper.
Yeah, we also had very few people infected. I think, one respiratory therapist and one of our intensivists, but I know the intensivist got it from his wife, who is not a physician. So it seemed like the number of people who got it from work was extremely low, if any.
There's also a question in the chat box about bradyuria systole being secondary to COVID myocarditis. I think that is a really great question that we don't have the answer for. And in our own institution, we have not seen that. We've only seen bradycardias in the setting of hypoxia.
Yeah, we've seen a few cases of myocarditis, although not as many as I think we were worried we would see from the early reports coming out of like Seattle and some other folks. But agree, not specifically bradycardia or systole from that.
And a great question about spontaneous pneumothorax causing arrest. I think that is something to worry about. Again, in our small case series, no. I don't think in Kate's either.
No. Always something to think about with high PEEP and low compliance, but
yeah.
I see a question about environmental precautions aside from HEPA filters. I think we tried to have, because obviously no hospital has enough negative pressure rooms for all of these patients, but I think we at one point in the surge, we had HEPA filters in basically every room, I think. And except for maybe the negative pressure rooms, I don't remember that we did anything else aside from, closing doors in every room. I think it was kind of an issue when we were converting, some of our large medical floors to ICUs, because the doors on the medical floors are solid doors that you can't see through. And so they had to basically convert all of those doors. For a while, they were going to keep the doors open, but I think there was a lot of pushback on that from the workers on that floor, including myself, and they eventually managed to switch all the doors so you could get ones you could see through.
Brinda or Cameron, do you have any final comments?
No, thank you everybody for tuning in.
Yeah, I think for me, it's just making sure everyone has PPE on, especially if you're working with house staff. We had a case recently this weekend, and just making sure house staff also, you're minimizing the number of house staff that go into the room and wearing PPEs and protection before they even run into the code.
All right, thank you, everybody. I think we're done.
All right, thank you.
Thanks everyone.
Thank you.